Hello, and welcome to the webcast. If you would like to enlarge the video screen, just click on the icon in the lower right corner. Today, Gnida will be presenting on the history of CG-CAHPS. Jan, who has been with PRC for 20 years, is the Director of the Patient Experience and Government Surveys Departments. Questions will not be taken for today's webcast. If you have a question for Jan, please contact her directly. You will find her contact information at the end of today's presentation. PowerPoint slides will be sent to all who registered. And now, here's Jan.
Thank you for joining me for this brief history of the Clinician and Group CAHPS, or CG-CAHPS survey. The CG-CAHPS Toolkit was first published by the Agency for Healthcare Research and Quality, or AHRQ, in 2007, and a lot has happened with it since that time. This instrument is a bit unusual in the landscape of CAHPS surveys for a couple of reasons. One, it has gone through some version updates and changes, and two, it has evolved into a build-your-own survey. Unlike HCAHPS or home health CAHPS, there are many supplemental item sets available, and medical groups and practices are encouraged to take the core survey and add to it other specific aspects of care that may be relevant for their own patients. Two versions of the survey have achieved required status in the last few years, but that doesn't necessarily mean that the evolution is complete, and we'll continue to monitor updates and keep you informed of all the latest requirements and options. The definitive source for information about the CG-CAHPS survey is, of course, the AHRQ website, and I encourage you to spend a few minutes there to see what's available. Official survey versions and supplemental item sets are posted here, and you can also find a link to national benchmarking information to compare your results to other medical groups across the country. The site is a very valuable resource. CG stands for Clinician and Group. This survey was developed to assess the experiences of patients as they make visits to doctors and other healthcare providers in a clinic or practice setting. The initial development work for this survey occurred over a 3-year period, and it involved extensive literature review, cognitive testing with physicians and providers and patients to ensure that the questions and results are meaningful and understandable, and multiple field tests to evaluate sampling and methodology recommendations. As with all CAHPS surveys, the instrument and accompanying administration guidelines were reviewed by the National Quality Forum, and CG-CAHPS was endorsed in 2007. With this endorsement, AHRQ began publishing their materials on their website, and the survey entered the public domain, meaning anyone was free to use the instrument for surveying their patients. The survey follows the CAHPS principles of asking about the frequency of physicians and providers performing specific behaviors, and we're capturing patients' perceptions of these activities because the information cannot be found in patient records. AHRQ understands that human recall isn't perfect, but it is the best source we have for identifying whether or not specific events happened during patient visits to their doctor's offices. So let's take a look at the survey instrument itself. What does it measure? The core survey is divided into 4 reporting composites, plus additional demographic questions used to classify patients. Again, consistent with other CAHPS surveys, questions are grouped by aspect of care and will be publicly reported as these composites in order to not overwhelm consumers with too much information. We're asking questions about access, about the interaction with the physician or provider, and about the office staff in the practice. The core survey concludes with an overall rating question focused on the physician or provider. We're going to look more closely at these composites, but before we do, let's look at options for the core survey. The very first survey developed was intended for adult primary care visits. Then another version was created for adult specialty care visits, adding a few more questions that would be unique to the experience of seeing a specialist. A separate expanded version was created for measuring pediatric primary care visits, again building on the core and adding questions that would be unique to asking parents about the care their child was receiving. So as a starting point, we've got 3 versions to cover 3 different categories of patients, and a medical group would need to identify which kinds of patients they want to measure. Some may only want to talk to adult primary care patients. Some may want to conduct surveys with all 3 of these patient categories. The next decision to make is this: what do you want to use for the survey questions frame of reference? The first survey developed used a 12-month frame of reference, asking patients to reflect on all of their experiences in that doctor's office over the last 12 months. That might be 1 visit, that might be 20 visits. The patient is instructed to think about all of them. Recently, AHRQ has announced plans to modify this core survey version, shortening the frame of reference to 6 months. The shorter time frame yields the same information basically, while reducing the burden and anxiety for patients to recall visits that happened a long time ago. In response to significant feedback indicating that a survey about patients' most recent visit would be more valuable, AHRQ released the visit-specific survey version in 2009. Many physicians expressed that questions asking about a particular visit would be more useful in their process improvement efforts. Being able to tie results to a specific point in time would allow them to better understand the impact of changes they were making in their practices. Some physicians felt that the results would be more credible as well, perhaps a little more objective and a little less subjective, since the patient wouldn't be asked to average their experiences together. With this option, medical groups have latitude in determining if they want to interview patients on a weekly basis, on a monthly basis, etc. Among PRC clients, this has been the most frequently used survey version. The most significant difference between these two versions is the response scale. Now, if you're ever playing CAHPS trivia, it will be very useful to know that the first version of the CG-CAHPS survey, the version that was endorsed by the National Quality Forum, actually used a 6-point scale for responses. This was an artifact of the time and the development work that AHRQ was doing in other areas. And the more common 4-point scale of never, sometimes, usually, or always was quickly added to the mix. There are very few groups using the 6-point scale anymore. With the addition of the visit-specific survey, asking patients about what happened with their doctor during one visit, the never to always scale doesn't really make sense. So AHRQ created the 3-point yes-no scale. As we look at the survey questions, we'll also look at how these scales are used. The survey opens with questions about access. Are patients able to be seen as quickly as they need? Are patients getting answers to their questions when they call in? The first question, for example, is worded as, in the last 6 months, when you phoned this provider's office to get an appointment for care you needed right away, how often did you get an appointment as soon as you needed? Because all of these situations may not be applicable to the patient's most recent visit, these questions use the 6-month frame of reference in both versions of the survey. It makes more sense to ask a patient to reflect on these things over time. The exception is the question about being seen within 15 minutes of the appointment time. In the visit-specific survey, that question is asked both ways. Once about how often that happened for all of the patient's visits over the last 6 months, and once about whether or not this happened at the most recent visit. After access, we get into the meat of the survey, asking about what happened between the patient and the physician. The questions all begin with in the last 6 months or during the most recent visit. Example questions are, in the last 6 months, how often did this provider give you easy to understand information about these health questions or concerns? Or, during the most recent visit, did this provider spend enough time with you? The item on information about health questions or concerns is only asked if the patient mentioned that yes, he or she asked questions or expressed concerns. Results of these 6 questions are averaged to create a score reflecting how well the provider communicates with his or her patients. While the focus of the survey is on the physician or provider, the AHRQ does include 2 questions to measure the experience with other staff in the office. These questions are relevant for both survey versions and appear with the corresponding response scale. An example is, in the last 6 months, how often were clerks and receptionists at this provider's office as helpful as you thought they should be? The core survey concludes by asking the patient for an overall rating of the provider on the CAHPS standard 0 to 10 scale. This question is reported on its own, not combined with any other question, and the 9 and 10 responses are added together to create the top box score. The visit-specific survey does include a question asking patients about their likelihood to recommend the provider as a second global rating item, but this question does not appear on the 6-month version of the survey. As I mentioned earlier, the CG-CAHPS Toolkit from AHRQ allows medical groups to design your own survey. We've looked at the choices for a core survey, and now we'll talk about supplemental questions that can be included for your patients. All of these item sets can be found on the AHRQ website referenced at the beginning of this presentation. So from the AHRQ website, culturally competent care is defined as care that is responsive to diversity in the patient population and cultural factors that can affect health and healthcare, such as language, communication styles, beliefs, attitudes, and behaviors. This item set includes questions about communication and access to language services, complementary and alternative medicine, possible experiences of discrimination, and experiences leading to trust or distrust. The Health Information Technology item set seeks to measure patients' experience with the new technologies being more frequently employed in the clinic or practice setting. These questions ask patients to evaluate lab and test results provided through the patient portal, email and patient portal communications, experience with e-prescriptions, and the physician's use of devices during visits. As more and more medical groups move into electronic health records, this might be a useful set of questions to include. You want to make sure that new technology, helpful technology, is not coming between you and your patients. Questions in the health literacy item set intend to measure how well health information is communicated to patients. It really expands on the communication questions already in the core survey and dives deeper to ask about disease self-management and communication about medicines, about tests, and about forms. This would be a valuable item set to use if you really want to explore matters of patient-centered care. The fourth supplemental item set available, and the one most commonly used, addresses patient-centered medical homes, or PCMH. The medical home model is a growing concept for delivering primary care to patients of all ages. Patient experience is a vital measurement, along with many other metrics, to determine the effectiveness and success of this model. The PCMH questions expand on the access and coordination of care topics already covered in the CG-CAHPS core survey. This item set also includes the new topics of self-management support, shared decision-making, and behavioral health and whole person orientation. Many of the topics in the other supplemental item sets are also included in the PCMH questions. The National Committee for Quality Assurance, or NCQA, offers PCMH recognition and distinction in reporting programs using the 12-month survey with the PCMH item set. While not required, many practices and medical groups do participate in these NCQA programs. To close this presentation, let's talk about requirements. What do you have to do? If you viewed the first webcast in this series regarding CAHPS for ACOs and CAHPS for PQRS, you know that CMS has begun incorporating CAHPS measurement for these two programs. Depending on your status as an accountable care organization or as a group participant in the physician quality reporting system, you have either already started measurement with an official CG-CAHPS instrument, or you'll be starting measurement within the next couple of years. The webcast regarding CAHPS for ACOs and CAHPS for PQRS goes into greater detail regarding the composition of these surveys, and it can be found online at www.prccustomresearch.com in the Events section under On-Demand Webcasts. Both programs are using the same 80-question survey, although ACOs have the option of using a slightly shorter version. In this graphic explaining the full structure of the survey, you should recognize items 1, 2, 3, and 8 as the CG-CAHPS core survey that we talked about previously. Some of these additional topics came from the PCMH supplemental item set. Some of them are brand new topics that CMS felt would be valuable to track related to patients' experiences in their doctor's offices. These tools give us a great example of how CMS began with the CG-CAHPS core survey and then expanded it to include other topics of interest. We can expect to see this type of development occurring when they institute future measurement programs for other non-hospital-based services. The CG-CAHPS instrument has had a busy past, with many versions changes along the way. I hope you now feel more familiar with the evolution of this survey and have a sense of how it may continue to grow and evolve in the future. For more information about PRC solutions that are available for your practice or medical group, please contact me or visit our website at the address on the screen. Thank you.